Hello and welcome. Thank you so much for joining me today on Carroll PMC's video interview series. I'm excited to have you all with me today as we discuss another's journey through medicine. And today I have a great guest for you all, Dr. Mike Strekall. He is a Carroll College graduate who attended medical school at the University of Washington School of Medicine and also served on the admissions committee there for a few years as well. Dr. Strekall has incredible insight into the world and practice of family medicine. From his residency years to his 20 plus years at St. Peter's, we engage in a discussion about bedside manner, the future of medicine, and the importance of the continuity of patient care. So let's jump right in and say hello to Dr. Strekall. Welcome, Dr. Mike Strekall, to Carroll PMC's video interview series. It's great to have you here with us.
Thank you. Glad to be here.
When did you realize you wanted to become a physician?
I think that probably started when I was close to a freshman year in high school. Had some experiences through my family, some illness. A surgeon who lived actually next door to us, I got the chance to observe him quite a bit, knew his kids, and he was one of these really compassionate Marcus Wilby type guys. Knew lots, was trained at Mayo Clinic back in the day, and so he was kind of a role model. I said, I don't know if I want to be a surgeon, but he's the kind of doc I'd like to be.
Was it, I'm just wondering because HIPAA makes it quite hard to do shadowing, minus the pandemic that's going on, that's an additional variable. Was it just like hey, would you like to come watch me in the hospital, or how did you get permission to do so?
Well, actually, back then that wasn't really in vogue, so you didn't really get to shadow anybody. I actually, going to Carroll, I decided to, actually it was my senior year at Carroll, I decided to take basically a nurse's aide training at the VOTEC while I was at school at Carroll, and so I wanted to become an orderly this summer between med school and college and med school, and so I got quite a bit of experience there. I think prior to that, it was just happenstance. It just seemed like it fit. Sounds strange, but yeah, I've been wanting to be a family doc actually really ever since close to the end of graduation of high school.
That's interesting that you had the specialty in mind too, because everyone's got their different favorites and specialties, but from the medical students I've spoken to, a lot of them, they go in thinking one way and then they come out after third and fourth year and they're just in an entirely different realm. I'm curious, is there any history of medicine in your family at all?
No, I'm it.
Oh, you were the first.
I had business people and farmers and ranchers actually in the connected family, so yeah.
That's interesting, and everyone's got a different background, parental backgrounds as far as getting into schooling. What did your parents think about you going into medicine?
Well, they were supportive. I think they kind of wanted me to do something that I had goals toward, or I wanted to achieve some things, and so they were very supportive. They kind of encouraged me. I think I got very little negative. In fact, I got no negative feedback from them at all. They were just sort of like, go for it, and if that's what you want to do, check it out, see if it still interests you after you've been in school for a while, and actually, going through Carroll, I think it was a pretty important step for me to choose Carroll. I actually didn't choose Carroll till June, the year I matriculated. I was a late thinker or whatever. I was accepted to Gonzaga and to Creighton, but after thinking about that and measuring what was available, it's like, Carroll actually had more to offer than those two schools. It was a little bit smaller, yeah.
Mm-hmm. Where are you from again? Where did you grow up?
I was born and raised in Billings.
Oh, okay, nice. So you were
in family kind of up and down the mountain front here in terms of from Butte all the way up to Conrad, and several parts in between. So yeah, my grandparents lived in East Helena, and so that was a good drawing factor, being able to come, and the plan was to come and spend time with them. So yeah.
Sure, yeah. And so speaking to that, I understand you're Carroll College alumni and you were a biology major, if that's correct. And what drew you to Carroll? Then you said you had some family seeds in the Helena area, but what drew you to Carroll, and specifically specializing in education that's in the sciences?
So, I checked out the reputations really of Carroll, MSU, U of M, Creighton, Gonzaga. I looked at their curriculum a little bit in terms of what they offered, but I also was interested in their acceptance rates. I kind of figured, if they have a high acceptance rate and you're able to handle the workload, the chances of getting in were pretty high. So I think that weighed into it. Plus, there's a history of Carroll. Dr. Jim Mannion was the head of the biology program back then, and he was well respected around the entire country. People just knew him in many medical schools, and so I figured, this would be a chance. And if it didn't work out, then I would try something different. But it worked out. Yeah.
Yeah. So you came in really with your sights honed down on medical school.
Yeah.
So that it sort of seems like you are sort of leaning towards the traditional route, because oftentimes the late bloomers who come to Carroll and maybe realize they want to go into medicine towards their end of their sophomore or junior or even senior year, oftentimes they take a non-traditional route, which is basically really anything, at least right now, it's anything besides just going straight into medical school after undergraduate. So did you take any gap years at all, or did you just go straight in?
No, I was pretty straight through. Yeah. You mentioned the students who are really less traditional, that they may come in 5-10 years after they graduate from college, go back to college, pick up the required courses and go to med school. So I had a chance to see quite a bit. I did about 5 years of interviews for the Montana group for the WWAMI program out in the University of Washington. So I got a chance to see the other side of that after I was in practice here in Helena. And we got to interview students from across the country, but they were all Montana residents. So they went to different schools, but they were still residents in Montana. And so, yeah, you could see that. We had quite a diversity in our class. I think the oldest guy when starting, he was like 31. And the rest of us kind of ranged from 23, 24, 25, 26 years of age. So Bob was the old guy, and he was married, and he was just this great guy. So, yeah, there was a good mix. It actually made a better class because we had diversity.
Yeah, diversity is really important when it comes to a lot of things. Like it just seems like there's more inquiry here on campus, where when we're in classroom discussions and everybody can bring their own personal backgrounds into the answers that they have and the opinions they have. And so, yeah, it promotes great inquiry. I'm curious, you're quite it seems like you're quite a straight shooter. So there's an option to actually graduate Carroll after only about 3 years. And really the only major that you can feasibly get away with that and get into medical school is biology. Did you graduate in 3 or 4 years?
I didn't want to graduate in 3. One of my med school classmates graduated in 3, and what I saw was he just missed out on the humanities and some of the things that you could lace through the years of college. So he was strong in the sciences. He's a brilliant guy, but he kind of missed out on that. And I think that helps form one's character. So I hated history. Man, you couldn't pay me to go into history. And then I heard about this doctor, Father Dr. Graytack. He taught history, and I finally said, well, gee, my junior year, I probably should take one of his classes. Well, I wished I had started like 2 years earlier, because I didn't miss a class my junior and my senior year. I mean, it's just, he made history come alive versus just the dead stuff I experienced in high school. So, you get that chance at Carroll to meet some of the professors, hear about them, understand that they themselves are straight shooters. And so taking classes, it was actually a lot of fun. Business law and art and music and economics and social studies, all that stuff. Some of it's required, but much of it wasn't. But I was interested in getting a well-rounded education. That was something that Jim Mannion actually stressed. He kind of wanted well-rounded pre-med students. And if you were going to apply to med school and you were pretty much linear and a hedgehog, he wasn't have much interest in writing a letter of recommendation for you. So diversity was actually stressed very early on, which fit for me just fine. I thought that was a great idea. I belonged to Circle K club, and we had big brothers, big sisters, and we did things on campus. It was actually kind of fun. I had never done any of that during high school. I played tennis and intramural sports and studied in high school and had lots of friends, but Carroll was a new twist.
Definitely, yeah. You were a member of Circle K Club, it sounds like, and one of our up and coming treasurers is actually a member of Circle K as well. What did the club look like back then?
I was one of the younger guys there because most of them were juniors and seniors, so I was actually a sophomore, and it was really kind of an opportunity to look at service for the community of Helena. Not too much on campus. We had some fun on campus, sponsoring back then parties that had alcohol at them. So we were all underage by today's standards, but we were all 18 years of age at that time, and so it was legal drinking age in Montana. And so we actually made money that we could then take and utilize in the community to do things. So it's kind of it was, not just a drinking kind of a club. Actually, there was a mixture of people, a lot of academically driven people. And so we did a lot of thinking about what we could do with whatever funds we gathered together. And of course, the Big Brothers, Big Sisters that was a spinoff. And most of us did that, adopting a little guy for me, and he was a single parented kid, and he didn't really have too many opportunities, but I had a car, so we actually got a chance to do things. And he and his mom, we got together, and she kind of figured out that, gee, we were fairly genuine. We actually wanted to do things, not just show on my resume that I'd done that, but we got along great. Had a lot of fun that year. Played sports, went to movies, went to ball games, did some artistic things, did a little bit of music. Kids who were, I think he was about 8 years of age. He hadn't had much exposure and had no male prototypes to follow really in his life to that point. So I tried to be a good role model. It was fun. Yeah, it was good. I don't know if they're still doing that, but if not, they should.
Yeah,
more of it than he did, I'm pretty sure. Yeah.
Well, we're working on a collaboration with Circle K in the future, and so hopefully meshing our strong suits together, we can do something pretty great for the community. But it's good to have someone on board on our sort of officer pool that knows that club pretty well, and it has a great impact on the campus still to this day. So that's great. It's very interesting about the alcohol side of things.
Yeah, and we actually monitored things pretty closely. We didn't want anybody walking out too intoxicated, and nobody was driving. So we kind of, part of our job was to have a party, but the other part was to make sure people got home safely. And yeah, we took that on kind of as a pretty significant responsibility. We cut people off if they had too much, and just like you have to.
Right. Yeah.
But you couldn't buy alcohol, but you could buy tickets. That was the legal workaround on campus. So you could buy tickets to the event, and then you could buy a beverage with your ticket.
Oh, okay.
No money exchanged at the location where alcohol was at. It was at the door. But you could go back and buy more tickets if you wanted to. Yeah, it was a very interesting ploy of how to legally skirt around, can't sell liquor on campus, but we could have liquor on campus. Back then, I don't know what those rules are now, but yeah.
Probably not as they probably aren't as loose as they were back then. That's quite interesting.
But that was the first year they'd done that, so that had just happened. So I guess we were the icebreakers, or maybe we just cracked ice open and poured it over things. I don't know.
Oh man, that's interesting. Yeah, I'm very glad we touched back on that again, because I was going to move on to bigger and better things, but that's quite interesting. And just curious, before we move on from Carroll, what was the atmosphere like as far as pre-med goes back then? Was Carroll still considered, like, Carroll has a distinction of being notable for nursing and medicine for people graduating and going to those careers. Was it notable back then as well?
Oh, very, very much so. Yeah, it's particularly medicine. Nursing was building at the time. And they had great students, and they had good placement, and they had an excellent professor who was kind of managing the nursing side. I actually was a lab TA for the nursing group for a couple of years, I guess it was, setting up labs, etc. But the pre-med program was well known. It was well known across the whole state and this whole sector of the country. So it was very, it was good to get into that program. And, looking back, it was like, yeah, it probably helped form some of my decisions. It helped me become a better person. Really, I learned a fair amount from my professors, and having small classes, knowing your professors, the core professors well, you could, it still exists that way, because I'm involved in scholarship committee, and I hear from students that, yep, those students they still have access to most of the professors, and of course the professors' names have changed, but I think their goals and their academic skills, their teaching skills have stayed pretty hot. So that's good.
Yeah, definitely. It's a great place to grow as a pre-med, I think. And so you move on from Carroll to applying to medical school then. Can you give us some details about how that process went, applying to medical school after Carroll?
It was a lot of work, actually. It was actually, the application process for me was during my junior year. So it was really the same time I was putting together honors thesis type stuff, but the application process took a ton of time, and we did have some help, I think, from the upperclassmen. That turned out to be critical. We didn't know about it since we were underclassmen, but that sort of pass it forward, pay it forward. We actually did the same thing as we became the seniors. We're pretty much going back and meeting with the sophomores and the juniors, and setting up timelines for them, or letting them know that there were certain application dates you just couldn't miss, and you want them done ahead of time. You don't want to put the application in the mail and send it a day before it was due. It's like, no, there was just none of that nonsense if you were serious about it. So kind of creating a flow chart so you knew exactly what was happening. So once you sent applications in, there were secondaries you had to send in, but there was a time frame, and if you didn't hear, pretty much our upperclassmen had instructed us, call the schools, make sure you got the information, make sure it's processed correctly. If they're missing anything, what are they missing? And then if, let's say it's a letter of recommendation, you'd call whoever you'd asked and say, do you have time to do it? If you don't, I understand, but I can ask somebody else. So you kind of had to have a backup for like the letters of recommendation just to make sure. But it actually took a lot of organization and effort, and then pursuit in terms of making sure that everything got in on time and there was no lag. And it, went along with the MCAT scores. You had to make sure you took the MCATs. A lot of us took them in the spring, but then you had a chance in the senior year to take them in the fall if you actually wanted to improve your MCAT scores. And so some people did. I actually did that, but not everybody did.
Yeah, it's
fascinating. I didn't study at all for any of the sciences for the second MCAT, the science, the math, and that stuff. And so my scores were really quite high on those, again, the second test. And back then they had some other issues that, it was like art and language, believe it or not. So I learned 1,000 words that summer while I was painting houses. And I read 2 art books. Sounds pretty hokey, but my scores jumped up probably 40% on those 2 areas, which made it, highly competitive. So that it did help me. I put up with what had to be done for those areas that I didn't think was that important. But the MCAT back then, that's what it was all about. So.
Yep, and it's very interesting now. There's still the biology, biochemistry, and there's chemistry and physics, and then now there's 2 sections that are a little bit different. There's like CARS, which is like a critical analysis and reading section where you just read passages on various different things, and really it's just about what information you grab from there. And then there's a psychology and sociology section, which is on tons of different psychology terms. So it's almost like kind of like the memorizing 1,000 words. Like nowadays it's memorizing 1,000 psychology and sociology terms. And that's really what
really exciting. Yeah.
Yeah, it's very interesting. Some of the terms seem quite excessive, that each individual word needs to have a specific definition. Sometimes seems like you don't need a word for that. That just is something. But the MCAT's interesting. I actually took the MCAT during last summer. It got canceled 4 times with the pandemic, and I actually took a shortened version of it because during that summer, to abide by social distancing and to get the people in and out of the testing centers as quick as possible, my MCAT was not 7 hours, it was 5.5. Now
Wow.
back to 7, so everyone else is unlucky, but that's how it was for at least that period of time. And honestly, a lot of schools and a lot of committees really across the US, a lot of them are pre-med led and medical student led as well. They're actually looking at trying to get rid of the MCAT. What is your opinion on that? Do you believe that the MCAT is a testimonial to it's a testimony to whether or not you can handle the harsh hard education of medical school, or do you think it's something that might just be an obstacle that we can get rid of?
That's an interesting question. I've always basically looked at that, especially when I was doing interviews at the University of Washington, trying to analyze, look at different schools, look at Stanford, look at Yale and what they did. Um, and I guess I've always felt that, if you can't retain the knowledge that you learned and spit it back in a cohesive fashion, that probably would reflect upon you in terms of what you can do in your career. So, I'm a family doc, and I've always sort of been interested in that. So it's, if you've seen something once, you need to file it away. So if you ever see it again, you have a good opportunity to nail down the diagnosis, get the treatment plan, etc. So we didn't really have Google back then. We had like real textbooks, which you did fit in your hip pocket and just carry around. And so, yeah, it just didn't have that chance to have the mobility. I love now. I mean, I think it'd be kind of fun now to be in med school, because you could Google, YouTube, a whole bunch of stuff that, we talked about but never saw. So I think the learning curve, it'd be a lot more fun, actually. But the maintenance of information, I think, is pretty critical. I think the MCAT, some people don't test well, and I understand that, but most people do. So those who don't test well, for whatever the reason is, they're in the smaller group, and they're more the minority of people that, it's not perhaps a great test. I think it'd be better if they expanded that opportunity that, let's say you're not a great test taker, then there may be other modalities to emphasize the med school, that you've got the competence, the drive, the willingness, the capacity in your head to actually put it all together and keep it there so you could use it during your career.
Right. Yeah, I completely agree with that. And I think that's where a lot of schools that are going for like a holistic admissions process, I think they're going in like the right direction, because where like a low MCAT score might show off something negative about you. And maybe you're passionate about some hobby, let's say soccer, and then you became a leader of soccer, and then you started like a community program, and now it's one of the most popular programs in the community. I mean, that's a great way to demonstrate a passion and then empathy for others, and maybe something that medical schools might be a little bit interested in. So I don't know. I think that one of the remedies for that possibly could be the holistic application process. It's something, or admissions process. It's something that a lot of schools are adopting right now. Yeah, you see it a lot in when you apply to medical school these years. Like last year, every single school emphasized being a holistic applicant. It's just hard to get over those two big scores, the MCAT and the GPA.
Yeah, and I think, GPA, Yale and Stanford, those folks, they tend to use the GPA from a school that they think is competitive. And they just sort of figure, well, if you got a great GPA, you're okay. And I think there is some truth to that, I remember interviewing a history major when I was at the University of Washington. She'd graduated from one of our state schools in history, just aced it, went down to the middle part of the world, basically Honduras, etc. Wanted to get involved in the leadership down there, but unless you were a physician, you couldn't make changes in public health policy. So she came back to school, basically aced all the classes one could take in 3 semesters. And she did she actually took organic and inorganic at the same time. She did all that stuff at once, aced it all, and then applied to med school. And I remember meeting with her, interviewing her, and then after the interview, we could actually had a chance to sit down and talk. And that's when we found about her passion of what she was doing. But she was just a brilliant young lady. And of course, we accepted her on the spot, which didn't happen very often. In fact, it only happened a couple times the 5 years I was out there. But she obviously had the passion, and she says, well, I've already gotten into Stanford, I got into Harvard, but I actually want to come to the University of Washington. It's the best school for what I want. It's got a strong specialty background, has a strong primary care background, and I want some of both of those worlds before I go back down there and get involved. So, yeah.
Yeah, it's interesting that you were on the admissions committee, and so when you guys are looking for getting into the mindset of a medical school admissions committee, when you guys are looking for applicants that fit the class and that'll be good, are you looking for? I mean, I hear a lot of like what the girl wanted and what her passions were. Is passion one of the biggest factors you look for in applicants in order to say, hey, you know what, we want this person with us? Or is it something more than just passion?
Yeah, it's a mixture. So I think there's a passion to go to medical school, and and I sit on a scholarship committee with the Corrett Scholarship Committee and Semperman's Math Science Scholarship Committee, and so when we interview students specifically for Corrett, I'm interested usually by asking, so what if you don't get into medical school? And a lot of the students don't have a clue I'm going to ask that for some reason, even though this happens every year. My interest is hearing, I'm going to reapply. But in the meantime, I've got this other plan. And that's what med schools want to hear. And that's kind of that commitment, that passion kind of thing that says, hey, if I don't get in, there's 2 people qualified for every slot. If this year I just can't get in, I plan to reapply. And then obviously defending, what are you going to do for that year? Defending meaning, do you have a plan? Have you thought about it? Not everybody gets in, but that doesn't mean you're not qualified. That's just that year. So I think that becomes part of, that interview process or the application process. You have to sort of say to yourself, I'm spending all this money, spending this time, I'm working hard, I've got other responsibilities at college, and I was doing an honors thesis at the same time. If this doesn't work out, what am I going to do with my life? And so a biology degree is not real marketable. It's, at least I didn't think it was. I had planned to go on to a master's. I hadn't picked the field, but I figured I would do a master's, then reapply, and that was my backup plan. And fortunately, I didn't have to use it.
Right. Right, but so long as plan B and C and D and E all go back to plan A about being a doctor. I said that on here before, but that perseverance is, I suppose it's a really important thing. And if anything builds your perseverance, it's a pandemic. And so I really hope the next couple generations of students, with these resources that PMC offers, and with just Carroll in general and their own perseverance, I hope they go on. I hope they continue on. And I'm going to do everything I can for the last couple months I'm here to try and help that happen. And we got a great official team that's going to transition to power after us that I think will be able to help that out. And so University of Washington is one of the top drawing universities or medical schools for Carroll students. A bunch of Carroll students matriculate into there every single year. What drew you specifically to University of Washington?
Well, like you mentioned, so first off, it was like top 5th in the country back in the day. I was applying for universities that received grants from the government, basically for research. And so that's like one end of the spectrum, but it also had a very strong commitment to primary care, which is sort of a unique issue for a university to have both, because they really are at polar opposite ends of the spectrum. Primary care, you can do some research in primary care, et cetera, and that was an opportunity that we all had. We spent, a summer or a semester, or whatever, doing some things, kind of get our hands wet, learn about statistics, et cetera. But the professors that we got into, that we met, that were at the other end, they were the super specialists. They knew what was going on in the world. Whether it was, infectious disease. I mean, they were the people that you relied on during residency. You could call back and actually get advice from them because you already met them. So, but UW was that way. Of course, it's a whammy site, and so there were 20 slots back then. There's now 25. And so the odds of getting there were a little bit better. And then lastly, of course, the tuition was in-state tuition. So we're still going to walk out with debt, but nothing compared to any of the other schools I looked at. So it's kind of like, well, I'm going to have educational debt, but I'd rather finish paying it off before 30 years. Yeah.
Interesting. Yeah, it's interesting that they had the primary care emphasis as well. And I think it's kind of pushing you towards family medicine. Now, what just for our listeners who are interested in primary care and family medicine, what research opportunities really exist in that field?
So, if somebody matriculates at University of Washington, there's a requirement still to participate in research. So it could be a summer abroad, which, I guess if you got the money to travel, et cetera, and COVID doesn't exist, that might be an option. But doing some, basically, at least in my opinion, the standard med student isn't geared toward research. But since you use that data all the time looking at papers, if you immerse yourself in the middle of it, understand the process, look at the grunt work, look at how data is collated and brought together, and then analyzed statistically to come up with a conclusion, kind of like using the scientific method to the extreme. That was a good learning experience. So you could be a little more critical, or maybe I should say a lot more critical of articles that are written in the science literature. You look at the number of participants, if they were docs, or if they were, not docs, but patients, or if they were animals. You know, they had 33 things in the study. It was like, yeah, well, how statistically significant is that, you know, 16 of them came down with something. Yeah. So it was very helpful, I think, for me to frame that look at medicine and make sure when I was reading journal articles, I could actually dig it apart, make sure it was actually valid. And so that's what that whole basically semester, I did for a whole summer, actually. That's kind of what I got out of that. I never wanted to be a researcher. There is a pathway at the University of Washington called the MD PhD program, but that is highly sought after. Your typical 4-point students, your top MCAT scores, you might get an interview. And then if you get an interview, you better really know something about the research happening at the University of Washington, because they just don't take anybody. And I think they only take 10 or 15 a year across the whole country. So those are great opportunities to become a research scientist. Yeah, that's what the focus is there, not MD and practice medicine per se, more like the PhD side. Yeah.
Sure. Yeah. And that term has floated around the club before. I actually have a roommate who's a couple doors down right now who is planning on applying MD, PhD at some point. But he is interested in that major research thing. And yeah, it seems though that that's a supplementary aspect of being a physician. But for you, it seems like it's more that care, that provider, like that is what you're going towards, and specifically family medicine still. And so while it doesn't seem like, while it was created in childhood, oftentimes, I guess what I'm trying to get at is oftentimes a lot of the medical students and physicians we've had on here have said that really it took M3 and M4 for them to really certify themselves through clinical rotations and experiences that a certain specialty was what they wanted to do. And so I'm curious, did you have any experiences in medical school that really solidified for you that, hey, family medicine is exactly what I want to do. This is what I want to go towards?
Yeah, I think just about every rotation I had convinced me that I didn't want to be stuck with that one limited focus of medicine. I might know everything world about it, but it's like, you know something? If I know 90% of it, I can refer to my specialty colleagues if I have a unique situation. For me, it just didn't appeal to become a single specialty in terms of, you know, dermatology, surgery, you name it. I almost became an OBGYN because they're probably as close to a family doc, except they skip out, take care of the kids and the grandparents. And so, you know, that's kind of what appealed to me. I got a chance to spend my career actually taking care of multi-generations of people, knowing them, knowing their health. And it is more effective, I think, to have a family doc that does that, because there's things going on in families, and if you know about them, you kind of know what the solutions are. Yeah, it's more than just an earache or a sore throat. You know, the emotional things, the mood things are related to families, which are pretty tough on families. You're able, I think, to give better advice since you know what's going on, and yet you still have to maintain confidentiality between parties, which is a challenge. But you know, I just wear two hats. Today I'm wearing this hat. When I'm seeing your spouse, I wear the other hat, and the two don't mix unless you want them to mix.
Right. Yeah. Perfect. Yeah. And for people on here who are still getting acquainted with the specialties, can you just differentiate, because there's so much crossover, can you differentiate primary care physician, family medicine physician, internal medicine physician? So, you know, primary care is really a group of specialties. It's, you know, pediatrics, OBGYN, psychiatry, family medicine. Those are the core chunks. Internal medicine is kind of lumped in there, at least it used to be. And more often now, internal medicine specialties really aren't doing that, you know, because of reimbursement. There's not many internists that stay as a generalist. They decide to spin off and become a, you know,
GI doc or a cardiologist or a nephrologist, or because I think the reimbursement for internal medicine, it has basically been cut so poorly, so low by Medicare that unless you want to run a cattle herd through every day and crank out the numbers, you don't get a chance to do your job. And so more and more internists, don't take Medicare patients. Unfortunately, even more family docs are limiting their practices. If they're in private practice, they only take a certain number, which is a real disservice to humans that live in this country. If you look at the rest of the world, that's not what's happening. But it's all driven by payments. You can only, you make a good living as a family doc, but for me, it was, I knew I'd make a decent living, whatever that was. But for me, it was like, what do I want to do every morning? Get up. Every time I get out of bed, if it's 3 o'clock in the morning, go deliver a baby or go to the hospital, take care of a cardiac case. Back in the day when we did all that, that was just what I did. I didn't really complain about that. I thought I'd quit doing obstetrics when I got old and gray. Well, I'm getting older and grayer, but I quit obstetrics 15 years ago because the price of insurance was so high, it just was ridiculous to continue. So more family docs nowadays are being trained less intensely in OB. There are still fellowships in family medicine residencies that you can actually spend your 3 years in family medicine and then do a fellowship. They have fellowships in several things: OBGYN, sports medicine, occupational health. Those are some that I know exist. And so those are add-on years to regular residency. And you kind of come out as a specialist in that area, but also as a family doc that you have the background. So.
And for those wondering, what do those look like then? Is it some classroom didactic education, or is it you're in clinicals, you're in rotations, and how long does that typically last? Or tell us.
Are we talking fellowship? Or are we talking residency in family medicine? Which one?
We're talking after residency. Hey, I want to specialize in sports medicine. Like what does that look like?
So you basically have to apply, be accepted. It's typically at least a year, sometimes 2, additional training where you actually go and you'll spend intensive time with the specialists in that discipline. If you're doing OBGYN, you'll spend tons of time doing surgeries, doing obstetrics, learning forceps, learning all the things that a GYN doc needs to know. So you come out, sometimes with numbers greater than some of the GYN docs actually have. But again, that depends if you're a go-getter and if you're in the right program or not. Sports medicine, again, spend a lot of time with trainers, with physical therapists, with orthopedic surgeons, and you learn a lot of that stuff. You learn correct techniques for injections in a dozen different places in the body. And so if it really turns you on, you can become a real specialist in that one area and at the same time practice family medicine in a group.
So when you attended your residency, you did so at Yakima Family Medicine, which is a clinic that provides, as they said on their website, comprehensive medical care across the lifespan. And you alluded to this a little bit before. And before we get deep into your residency years, let's touch on it one more time. What about continuity in medical care? Do you see as beneficial to you as a doctor and to the patients you care for?
Without hesitation, continuity is critical, I think. It cuts the cost of medicine. It gets to the diagnosis and solution quicker. It's been well documented that even if you look at studies that are done and you look at a group of specialists taking care of the same patient and a family doc taking care of those patients, the family docs don't waste all their time repeating tests. The patient doesn't get 3 CAT scans of the same body part. They get one. It's utilized, it's moved on. So the care, I think, tends to be better. It's been shown that the outcomes are better. I kind of think that, in a way, if you look at family docs in the mainstream of medicine, they're almost kind of like the backbone. They hold it all together, assuming they accept that role. And that's a tough role. I mean, I've been doing this for quite a few years. And to receive information from 15 different sources first thing in the morning about patients that I haven't seen for 3 to 6 months, but they're getting their care, it's a little daunting, but it's much easier if you know the patients. So once you know the patients, you read that stuff, you file it away, and it's like, yeah. When you see them in a month or so, you know where it's been filed, you know what they've had, if they've had procedures done, parts missing, whatever. You can have a good conversation with them. If something is more critical, I call my patients on the phone and might say, look, I see what you've had done. I need to see you next week, or I need to see you in 2 weeks, and I'll order some labs for you, and I'll do some follow-up, because that looks like what they had recommended from the hospital over in wherever, Mayo Clinic. And so I think you can be pretty involved in their care. I tend to like to do that.
That's interesting too.
You can fly on the outskirts and not get involved at all. I think it's harder. It's harder to practice that way. It really is.
It's interesting because it's almost like you're a historian, just like you were alluding to earlier with your history class at Carroll. It seems almost like you're a historian and like drawing back from records regarding just to make sure that you're continuous in care with patients, and the care is more directed. I assume that the savings and costs also don't come from also just not repeating certain things, but maybe catching like an ailment ahead of time to prevent maybe some really costly treatment procedures versus, hey, maybe we could just start with these preventative options and maybe save you the trouble down the road. Is that something you see as well in your practice?
It really is. Yeah, you bring up a good point. It's if people learn who you are and they trust you, they actually will take your advice. Preventative medicine is huge. Whether they're drinking too much alcohol, they're smoking, they're doing activities that are risky, you have an influence, you have an opportunity. I mean, you deliver kids, you take care of them for 10 or 15 years, they're getting ready to go through high school and they're having trouble. If they trust you, they'll come to you and ask questions. They'll come to you to figure out, should I be doing this? And you have to do it confidentially, and parents that of kids I took care of, they just accept the fact that, well, they're not invited in the back. Their kid and I are going to have a conversation, and we're going to come up with some solutions. And if it looked like something I thought the parent should know, I always offered, I'd be glad to talk with your mom or your dad, and you don't have to be there, or you can be there. We can sit down together and I'll explain it so the heat's off of you. And, different young people actually accept that differently. But you can see, you can make a difference. Sometimes people haven't heard, you better quit smoking, you can get lung cancer, you have emphysema, and you've already put your 15 years into it, and then they ask for help.
Right. But
so preventative medicine saves a fair amount of money. Plus, it also is more satisfying to have healthy people.
Right. But I'm going to play devil's advocate for a second. As a new patient, let's just say new patient, and have a history of smoking. I mean, it's, or maybe quite obese. Like my eating habits are not up to par. These are very sensitive topics. Oftentimes, a lot of people have some emotions and maybe even trauma that are sort of preluding these things. And I assume over time, it becomes more easier to foster this trust. What do you do for that new patient, that new consult? How do you foster that trust as a family medicine doctor?
I think taking the time to figure out where they're coming from. And I always ask, so what are you seeing me for today? How can I help you? And I let them kind of talk, because I might have a bunch of ideas, but it's better that I don't stick my foot in my mouth right at the beginning. And my intention, people can figure that out, it seems like pretty quickly, is not to put them in the hot seat. And there's a technique called motivational interviewing. And so there are some ways to ask questions like, so how are you, what are you going to do to make this change? How do you see yourself making this change of eating less, smoking less, drinking less? What are the barriers? What are the risks? What are your benefits you're getting out of it? You get a great party time. Oh, that's wonderful. But those people are going to go away eventually. And so what are you going to be left with? So kind of trying to meet patients where they come from. That's hard work, especially early on. I think you get a chance to sow a few seeds on their first visit. If and when they come back, I think more work gets done. But some people take a few years to soften up. That's just the way it is. And then those who say, I'm not going to change. And I'll say, well, okay, I sure appreciate you letting me know that, but I've got some ideas if you ever want to change. And do you want to quit smoking? I've got some ideas, and they're really not such horrible things, but you really like to smoke, I guess I'll still take care of you. And that's an interesting commitment when you tell people that they're not expecting that. They're kind of expected to be shooed away, like, well, if you don't listen to me, goodbye. Here's the door. I have never found that technique very effective. And so I have repeat customers that eventually come back and say, you told me. And I say, well, and I don't think that saying something like, I told you so, is very helpful. Sometimes I say, well, I promise not to tell you I told you so when they come back. But I might say, like getting a flu shot, and if they've had the influenza, they didn't get their flu shot, I say, I'll take care of you, but after you kind of are well enough to survive, I'll probably offer you a chance to have a flu shot next year. And that sort of points a pretty good finger at, take care of yourself. Take on your own responsibility. I'm here to help you, not condemn you, not to judge you. And that's something that you have to learn, The judgment side is not helpful. That's not why people come to you. They come for assistance or for counsel or advice or whatever. They're not really coming for your judgment. So I learned that a long, long time ago.
Do you think those interpersonal skills were something you developed in residency?
Yeah, in the Yakima Family Practice Residency, when I did it, it's changed, but I did 1 year in Spokane at the big hospital at Deaconess and some at Overlake. And then the next 2 years were in the clinic in Yakima. And so that clinic in Yakima originally, that medical practice existed before residency, so it became a residency. And so you took care of people from all walks of life. You took care of the elderly who are 89 years of age, independent or in the nursing home. You took care of the teenagers. You took care of the bankers, the doctors, the lawyers. We had it all. We didn't have a typical family medicine residency, which took care of a lot of just downtrodden people that had no money. We took care of a variety, and so that was huge. And of course, our residency director was great, and he was a good role model. And we all, watching him take care of patients, you got the aha pretty quickly about, he didn't have to tell you, because you could watch it and you go, that was pretty effective. That was amazing that we could get that done, and these patients accepted your advice, and we got the project finished. Whether it was a minor surgery or a big procedure or a big family hassle that had to be handled, a breakup of a family. So yeah.
Yeah, it just seems like, again, you got to really be an all-around jack of all trades type of person to be a family med, because you just named off a bunch of different bunch of different patient presentations, and you at least gotta know a general gist of how to address it or how to listen to them, or what specialists maybe consult with to get patients more feedback or more helpful information. So,
yeah, family doc, that's really true. And I think then also important to me is knowing who in the specialty fields are at the top of their game. So if I needed some advice or specifically need the patient to see somebody, I know where to send them. So that just takes time. But utilizing my specialist colleagues at their maximum capacity. Doing the easy stuff, I do that stuff. When it gets right down to the wire where a decision has to be made about a chemotherapy treatment, whatever, my oncology buddies, hello, that they make those calls, not me. I might work the patient up, hand it to them on a platter, and say, okay, here's the problem. Offer the patient your choices.
Does it ever frustrate you that somebody always knows something more than you in like the oncology realm? There's an oncologist that may know more than you, or an OBGYN, a specialist, they'll know more than you about OBGYN stuff. Does that ever frustrate you? Or do you think that in order to pursue a career in family medicine, you really have to be open to collaborating with others and working towards with the patient still in mind and taking your ego in check?
Yeah, I think I don't even look at it as ego. I know some people might, but they probably aren't cut out to be family docs then. So you look at the patient's welfare and you prioritize that at the top end. You look at your own skill set and say, okay, so I know a lot about it. In fact, there's some areas that you may know as much as the specialists, but they might be able to do a procedure far better than you because they've done 50 of them this year and I've done 3. And so it's like, why would I not have my patient go see somebody who's done 50? if you can recognize that and accept that and say, that just builds great relationships amongst the specialist and you, which I've enjoyed most of my career. That helps get the patient to them, and they don't want to take care of the patient after they're done. Then they come back. And if I'm smart enough to see complications that are existing, get a hold of them on the phone, fix things early, that's a role that they've always appreciated, my specialty colleagues. The other side of the coin is, I just can't imagine just doing that all day long. Like, yeah. On rotations, you get to see that. You get to see, cardiology for 3 or 4 or 5 or 6 weeks in a row. It's like, yeah, I like the heart, but, there's more to it. The body's got lots of cool parts. And so I really thrive on the diversity. Yeah.
It's interesting, speaking about just family medicine in relation to other specialties, because quite interestingly, there's an ongoing debate as to whether or not family medicine should be considered a specialty or not. Some people think it shouldn't be considered a specialty, that it's more so you're a generalist. You got to know a little bit about everything, a mile wide and an inch deep. And so from rotations amongst your peers in medical school to conversations with other doctors in the break room at St. Peter's, what does your orientation to family medicine allow you to bring to the table? Where do you fit at the table?
Well, it's real interesting. Over my career years, you get phone calls from my specialty colleagues about, well, I've got this kid here, but he doesn't have an orthopedic problem. He's got this and this and this. What would you recommend? So it's like they're, I'm kind of going, well, that's one of the easiest things you can just take care of. I don't say that. It's very unkind. But you think, I deal with that every day. Why wouldn't this guy have a clue how to take care of an infected ear or a tonsil or a bladder infection? Simple stuff, or a pneumonia. I mean, they're just not geared up. They have no clue. So it kind of comes back around. I think you look at and say, this whole question of, family medicine specialty, if you look at the principles behind family medicine, which includes continued education, which many specialties are now adopting, but family medicine's had that all along. You had to keep up enough CME credits to stay accredited. You had to do your boards every 7 years. Now there's an option for 10, but during that, if you have a 10-year Strekall, you basically do stuff every year at a certain quantity, and it's diverse. It's in a variety of different areas to keep your skills up. Many specialties, when I graduated and went to family medicine, it was a one and done, and you could watch them getting outdated in their specialty as I aged and watched them not be further educated. But one by one, specialties have added those things back in. And you look at that and say, yeah, that makes sense. You're really good 10 years ago, but if you haven't done anything, do you even know what you're doing? And so I think family medicine pushes that, and rightly so. It's like, yeah, you never quit learning. There's always a reason to go to meetings. There's always a reason to learn a bit more. And of course, in the classroom called the examination room, I learn something every day. I just do. My patients are very gracious about teaching me things that I didn't know. And I like that. Up to date in Google and stuff, it can help, but you can't really do that in the middle of an exam. So yeah, that's something that in family medicine you get a chance to do, and I think that appeals a lot to me. The continued education, it's just a requirement. If you're not willing to buy into that, you're not going to be a very successful family doc, in my opinion. Yeah, first 10 years you'll be hot. After that, it's like, well, things change in medicine. And if you're not changing with them, you're outdated.
Right.
It's hard to keep up with everything. You're absolutely right. But you learn what you learn in residency. You come out of residency and you go, okay, I know lots about all this stuff, but what you really learn is what you don't know. And when you've got that figured out pretty well, you can be a pretty effective doc.
That's a really beautiful metaphor, comparing the examination room to a classroom of sorts. And we've spoken about change a lot and the importance of learning. And one of the members wanted to know what has really changed in the past in the multiple years that you've been in the field as a family medicine doc. And where do you think family medicine and medicine in itself, I guess, is heading in the future?
So, obviously reimbursement has changed. Medicare has influenced that, not so much in a positive way, but they keep revising that. It's tied to a whole bunch of laws that really won't get fixed. So that we'll be stuck with that. I think, you spend a fair amount of cognitive time in family medicine, and fair reimbursement for cognitive time is being pushed. And I think that's kind of the future. Big corporations have figured out that, if you get yourself a family doc group on board, the wellness of your entire group, and we're talking large corporations, they don't spend so much money, their employees don't miss as much work, they're healthier, they adopt some of the principles that family docs like to share or preach or whatever the right term is. So I think there's 130,000 family docs in this country. It's the largest specialty. So a lot of people in Congress, in decision making, in healthcare, if they have a problem, they typically want a family doc on their panel. So at the high-end leadership, which I've had a chance to do some years ago, be involved in the national organization and be at the Congress of Delegates and go to the White House and hang out with the senators and those folks. A lot of work, a lot of opportunity existed, but family docs have been involved in a lot of that transformation, trying to keep the patients focused. That's what it's all about. Take care of the patients that are, need the care. The rest of it will come together.
Well said. So as we wrap some things up, and as the Carroll Pre-Med is listening to this and possibly struggling on their journey, maybe thinking about the future prospects of being an excellent, extraordinary family medicine physician. However, there's a pandemic going on right now. It's very hard to shadow, and there's a lot of obstacles and struggles in the way. So what final words of wisdom do you have for that Carroll Pre-Med student?
I think there's a few things. I think staying motivated to pursue your goal, putting out the effort. If you have the aptitude, you put out the effort, highly likely you'll succeed at least getting to that goal. I've always thought that, doing classes outside your field of study, outside your major and minor, they're critical. That makes you well-rounded. You're more interesting to talk to. You have a conversation besides sort of like a hedgehog, very limited focus. And I think that's important. That's just fun. Plus, you're more interesting to be around. People, more people will think that you have something going on. You got an education out of Carroll. I think finally you look at, say, I wouldn't encourage any of the students to narrow their focus down. If they want to do medicine, they've seen surgery, they've seen orthopedic, they've seen whatever, they've seen, this is what I want to be. And I see that in the interviews that I've done with scholarship committee applicants. And first, after I listen to all their passion of what they've seen, I go, well, have you ever seen this? And they look at me like, well, no. Well, how about that? Well, no, I haven't yet. The point is, don't narrow the focus. Keep that door open. Go experience those things. Find out what turns you off. That's probably important. You might find out things that are really exciting that you don't mind getting out of bed for and going to work every day. That probably is your lifelong opportunity to avoid burnout. No matter what happens in the climate of medicine with reimbursement, whether it's COVID, whether it's limitations on what can be done in certain states, if you really like what you're doing, then all you do is got to find a place where you can do it. And if you like where you're living, you'll just kind of you'll thrive, I guess, be successful. Success is not always measured in dollars and cents.
And with that, we end another episode of Carroll PMC's video interview series and wrap up another story for you guys. I absolutely loved having this conversation with Dr. Strekall. I loved our conversation in regards to the directionality of our focus during these years as pre-meds. I think, like he said, it's quite easy for us to corner ourselves in one direction, in one passion, when in reality, college and pre-med years in general is quite honestly just an opportunity to explore various fields of medicine, various aspects of medicine, the positives of medicine, the negatives of medicine, and the positive and negatives is a bunch of other career paths and other career fields and people to hang out with and experiences to have. And then from those experiences and like he said, from experiences, not just word of mouth or etc., deciding ultimately whether or not medicine is right for us, for the pre-med. That is exactly the mechanistic way of approaching being a pre-med and pursuing my journey to become a physician. That's exactly what I've employed. And that's exactly what I encourage that you guys employ as well. Because in the interview room, it's going to come down to questions regarding motivations and specific reasonings as to why you've made decisions about your life. And the experiences that I've had make those questions a whole lot easier and make myself very confident on dictating that becoming a physician is what I want to do with my life. And I encourage you all to do the same, and I think Dr. Strekall would agree with me in this aspect of being a pre-med. Thank you for taking the time to listen or watch me today. Hopefully this helped you guys gain some motivation or insight into what it takes to become a successful pre-medical student. As always, if you have any questions at all, please feel free to reach out to your Carroll PMC officers, schedule an office hour slot with myself on Moodle, or consult Carroll faculty of your choosing. If you like this video, please like it, subscribe to the channel, and share this content with your friends. We want to reach out to as many people as we can who are interested in medicine. Have a great day, and I'll see you guys next time.